I'm Michelle Kittleson, heart failure transplant cardiologist at Cedars-Sinai in Los Angeles, California. I'm here with Dr. Rakesh Gopinathannair. Dr. Gopinathannair is Director of Cardiac Electrophysiology Laboratories at the Kansas City Heart Rhythm Institute. He authored the recent AHA scientific statement on managing atrial fibrillation in patients with heart failure and reduced ejection fraction. So when you have a patient with asymptomatic, rate-controlled atrial fibrillation in HFrEF, so they've had HFrEF for a while, we're not exactly sure of the duration, the two have occurred together. Do you ever give patients one shot an electrical cardioversion, or do you go straight to a rhythm control strategy with medications or ablation?
You can give them a shot at cardioversion, but the problem with that, obviously, you're only resetting the rhythm, but the drivers of AFib are not addressed, and that includes both specific atrial drivers and also the heart failure aspect of things, underlying structural heart disease. So my experience has been that there is usually a high risk of recurrence. And other option would be to use antiarrhythmic therapy along with cardioversion to maintain rhythm. Most antiarrhythmics are not very good at restoring. You have to restore electrically and then maintain that. But the problem is that so far, no antiarrhythmic has ever been shown to have any positive impact on heart clinical endpoints, and including amiodarone, including dofetilide. At the best, they are neutral, but they can sometimes increase hospitalizations with them because of their myriad drug-drug interactions and QT prolongation issues, all those kind of things. And we are very limited in our antiarrhythmic choices in heart failure with reduced ejection fraction. So again, yes, of course, in an acute situation where you are struggling to control their heart failure, absolutely you do what you need to do, short-term amiodarone, so that we can maintain rhythm. But then you have to think about, am I going to keep this guy on amio for several years? In those cases, what I've done is that I can electively ablate them, and when they are stabilized from their volume standpoint, and then think about a strategy of weaning them off of antiarrhythmic long term.